各位来宾，大家好，我是戴佩青，是风雅集医疗讲座的主持人。那欢迎大家今天晚上来参加校联会风雅集2025年第二场云端医疗讲座。今天的讲座非常荣幸邀请到 Dr. Yvonne Sada 林小凡医师。Dr. Sada 目前是 Baylor College of Medicine 的副教授，并且担任 Michael DeBakey VA Medical Center 首席血液科和癌症的医师。他是毕业于 University Rochester 的医学院，在 Baylor College of Medicine 接受 residency 和 fellowship 的 training， 并在 Michael DeBakey VA Medical Center 完成博士后研究。Dr. Sada 跟校联会是很有渊源的，他是1996年我们校联会奖学金的得主，他也多次参加校联会主办的职场精英论坛 Young Professional Career Forum 担任讲员，分享他宝贵的经验和提供建议。大家现在在 slide 上面看到的是 Dr. Sada 在2021年他发表了一篇文章 A Dozen Eggs。在这篇文章里头呢，他描述了他和一位变性病人之间问诊所经历这些复杂和敏感、微妙和同理心的过程。这篇文章呢，发表在被具有非常权威的 Oncology 的期刊上，而且入选为近10年来最有影响力的医学文章之一。我自己读了，其实蛮感动的。如果大家有兴趣的话，我们也可以把这张文章和大家分享。Dr. Sada 他不但是一个 physician clinician， 同时他也是一个 researcher。目前研究的方向分为3个部分，第一个是 guidelines adherence colorectal cancer treatment， 第二的研究方向是 risk assessment and treatment of older and multi-morbid cancer patients， 第三个他着重的方向是在 communication between physician and patients。Dr. Sada 他看病的是着重于在 GI 的 cancer， 他今天将会以英文来演讲，主题是 Cancer Prevention and Treatment。那我们现在就把时间交给林小凡医师。Dr. Sada。
Thank you so much for that introduction. Thank you so much for the invitation to speak to your group today. This is an incredibly broad topic, cancer prevention and treatment, that I've been asked to speak about. And so I'll give a very general overview and certainly welcome any questions at the end. Our main objectives today are to talk a little bit about how cancers develop, to recognize screening recommendations and potential early warning signs or symptoms of common cancers, and also to understand cancer treatment options and decision making. More specifically, as related to older adults, certainly some members of the audience may have older parents or family members who need to make challenging decisions, or patients themselves. So I'd like to start by talking about the estimated cancer statistics for the United States in 2025. When we think about the new cancer cases anticipated for 2025, in men, the most common are prostate, lung, and colon cancer. And for women, it is breast cancer, lung, and colorectal cancer as well. I would like to just draw your attention to the fact that diseases such as pancreatic cancer are relatively less common compared to prostate, lung, and colon and breast cancer, accounting for maybe 3% of all anticipated new cancer cases this year. The reason I'd like to highlight that is because the 3 most common cancers for men and women will likely lead to the highest number of cancer-related deaths. But even though pancreatic cancer only represents 3% of new cases we expect, nearly 8% of cancer-related deaths will be secondary to pancreatic cancer. I also just wanted to show what the probability is of a new cancer diagnosis by age, and this is data from 2018 to 2021. And I've highlighted breast cancer, colon cancer, lung cancer, and prostate cancer. And you can see that as we get older, over the age of 65, our risk of these cancers pretty much increases across the board. And in many cases, one of the biggest risk factors for developing cancer is age. And in fact, many people are living longer, and so we're seeing more cancer cases as a result. So before we talk about treatment and prevention, I think it's just a little bit important to talk about the biology of cancer and kind of how we get from a normal cell to a cancer cell. The most important thing to know is that cancer cells gain survival advantages, and they do that primarily by three ways. Their circuits or signaling systems are programmed to grow. Normal cells with damaged DNA are programmed usually to destruct, but cancer cells do not self-destruct when there's a problem in the code. And the third thing is that they've developed advantages that they continue to divide and grow for a longer period of time than a normal cell would. So when we think about how this happens, there are again three ways this can happen. So if the DNA code itself is damaged, if it experiences some sort of modification where maybe a different chemical compound attaches to the DNA and changes how the signal works, or if there is a mutation that changes the underlying structure of a cell. The second thing that can happen is normally when a cell makes a bad copy, there is a system where your body repairs the mistake. So another mechanism is that your body could lose the ability to repair a mistake. And the third thing is that cancer cells can gain functions whereby they're able to develop or sort of promote blood vessel supplies or the ability to invade into other structures. So when we talk about aging and cancer risk over time, things happen that increase the risk of copy mistakes and problems with repair. And so in the environment, things like ultraviolet exposure from sunlight, chemical toxins that may be present in the air or the water, or some people may have occupational exposures. Another one is lifestyle. So, smoking and alcohol use are probably two of the biggest risk factors for developing many cancers. And there's a lot of work going into diet and now obesity, which can cause kind of a chronic state of inflammation, can also be an increased risk of cancers. The third thing that we may not think about as much is actually the immune system. So, separate from cancer cells, even though we think about immune systems as fighting infection, they are sort of a patrol looking for not normal cells. And so, a normal active immune system may be able to detect and destroy a not normal cell. But as we get older and the immune system loses some of its function, it may have a weaker ability to detect an abnormal cancer cell. When we think about this, it's really a spectrum where over here on the left, these sort of bluish green cells are normal cells, but maybe a single pink cell develops some sort of change or damage. And that single cell can multiply itself. And then as you move into the premalignant or precancer, factors from the environment or our lifestyle or our immune system's ability to protect our body change, and over time, this can develop into a full-blown cancer. Now, I'd like to talk a little bit about cancer detection and the current screening guidelines and warning signs. I'd like to show this figure again, where we see the progression of a normal cell to cancer. And above it, I have an image of a normal colon developing into a polyp, which would be considered precancer. And then these white spots are essentially cancer cells developing. And then this last figure on the right for invasive cancer is when it starts to invade into the fabric of an organ. And the reason I wanted to highlight this is because screening is really for the pre-cancer part. We're looking for pre-cancer detection. As you move into the development of actual cancer, we still use screening to pick it up early, but then it's kind of a different question where how do we make the diagnosis early? If somebody, for example, has not done screening or something was missed on screening. So when we talk about screening, we have to think about, well, what makes a good screening test? Obviously, some cancers are more lethal than others, but they may be very rare. We only screen for common diseases where treatment is beneficial at an early stage. Because when we make a national screening recommendation, that means everyone in the country could get screened for an incredibly rare disease or one where us intervening early may not make a difference. And so sometimes screening restrictions or the age for certain restrictions may be the age for certain screening recommendations may be based on high risk factors to distill it down to the population that would benefit from it most. The second thing we have to think about is the test itself. Is the test reliable? If you have a test with a lot of false positives or false negatives, then it's probably not a good test. It also cannot be too expensive if you're trying to use it on a very large scale. And it has to be something that people can actually implement and do on a large scale and do it consistently. And I think a lot of what we'll return to today is to think about the patient themselves. So when we talk about cancer screening, we're trying to pick up cancers, obviously, at a very early stage. But you have to ask yourself in screening, does this patient have a life expectancy of at least maybe 5 to 10 years to make it worth going through the screening test? What are their other health conditions? So if you diagnose a cancer, can you still treat them? Does it make sense to offer treatment? And again, are they a candidate for the treatment itself? And do they even want treatment? Screening is checking once every 1 to 5 years, no matter whether somebody has symptoms or not. When we talk about red flags or symptoms to worry about for possible cancer, one of the biggest things is unintentional weight loss of 10 or more pounds. So if you're on a diet, if you're doing new exercise routine and you lose 10 pounds, that's normal. But if you're doing everything the same and you're losing weight for no reason, that is a red flag for further workup. Also, extreme tiredness. There are probably 100 causes of tiredness, thyroid function, lack of sleep, low blood counts. There's a lot of things that can do it. But if it's out of proportion to your normal, then that warrants further workup. New bone pain without recent trauma or fall. So, of course, over time, we develop back pain, shoulder pain. We all know what our usual aches and pains are. But if you have new severe bone pain, then that warrants further evaluation. For some of the cancers, I'll go over some cancer-specific symptoms, but I also think new changes in labs are also worth noting, whether it's anemia, new changes in liver function, or worsening kidney function without another cause. Again, based on the cancer statistics I shared earlier, I'm going to focus on the most common cancers affecting adults over the age of 65. Obviously, breast cancer, prostate cancer, lung cancer, colorectal cancer, and pancreas cancer. So for breast cancer, the national recommendation is annual mammogram. And for women, it starts at age 45. However, in certain high-risk groups, it could start as early as 40. There's actually no upper age limit for screening mammogram because breast cancer is very treatable. Red flags that you should look out for are if you can feel a lump on the breast, if there are new red patches, swelling, or almost like an orange peel appearance of the skin of the breast, and any sort of new discharge from the nipple or bleeding would also be concerning. Prostate cancer screening is a bit controversial sometimes. And the reason, again, is because there are some forms of prostate cancer where patients could live decades without any treatment. And one of the issues with the PSA test is that There are other things beyond prostate cancer, like an enlarged prostate, a urine infection causing inflammation. There are other non-cancer things that can raise the PSA. However, the recommendation currently is an annual PSA until the age of 75. Over the age of 76, you could consider continuing it if you're otherwise healthy. So if you have a patient who is 95 years old that has a very limited life expectancy, checking a PSA may not be beneficial just to check in that patient because that patient may not be a candidate for treatment. Some red flags, which I know there was recently a talk from urology, and the problem is that other things can cause these symptoms. But if there's difficulty with urination, frequency in the night, that warrants evaluation of the prostate. If there's blood in the urine, and this last one, prostate cancer very commonly can go to the bones. So if there is new sudden back pain associated with numbness or tingling, that would also be something to be aware of. Lung cancer, only in the past few years have there been screening guidelines developed for lung cancer. And this is an example where the last two we discussed, the screening is recommended for everyone. For lung cancer, it is restricted to a specific population, primarily smokers. So if someone has at least a 20-pack year cigarette history, which means a pack a day for about 20 years, and are over the age of 50, we would recommend a yearly CT chest to screen for lung cancer. And I will say, since lung cancer screening has been implemented, at least at the VA, where we have a high volume of smokers, we have definitely seen a shift where we have picked up many lung cancers much earlier when they're actually curable. So there is a role for screening in patients with history of tobacco use. Also, certain occupations. So, if there was exposures to asbestos, coal, diesel, uranium, soot, so any inhalation type exposures, that person should also be screened. Some red flags could be worsening shortness of breath. Obviously, if you get sick with a cold or pneumonia, you'll have shortness of breath. Or if you haven't exercised in a while and you try to run a 5K, you'll be short of breath. But if there is new worsening shortness of breath, a cough that's not going away, and especially if there's blood coming up in the cough, and the third one is because lung cancer often can go to the brain. So if you have new out of the ordinary severe headaches, any new changes in personality or the ability to sort of use your hands or your feet appropriately, those could be red flags that something is going on. Now, for colorectal cancer, there are many different options for screening. The general recommendation is that we should begin screening at the age of 45. There are some situations, for example, if you have a family history of multiple family members with colon cancer younger than the age of 50, some hereditary syndromes where people have lots and lots of polyps. There are some guidelines to start as early as 35, but that is a very rare slice of the population. So there are varying degrees of invasiveness of screening. I would consider the gold standard to be colonoscopy. Generally, with a clean colonoscopy, you could go 5 to 10 years before you do your next one. It is dependent on a good bowel prep, and if you don't take the bowel prep, they'll make you do it again and come back a second time. So take the bowel prep as hard as it is. There are also stool-based tests where you basically give a sample of a bowel movement and put it on a card and mail it back. So there are two ways to check stool. One is to check for blood because if a cancer is bleeding, then blood will mix in with the bowel movements. And so one way is to check for blood in the stool. There are newer tests where we look for basically cancer DNA in the stool test as well. These tests, though, have to be done more frequently, like once a year. Also, CT colonography is an option where you can basically do a very special form of a CT scan to get a three-dimensional picture of the colon as well. So these are all approved methods of colon cancer screening, and it is recommended from age 45 to 75. As we get beyond 75, it becomes more debatable based again on a patient's health conditions and their estimated life expectancy, if it makes sense to continue subjecting patients to screening. So certainly I've referred 80-year-old patients to GI and they've asked me, do we really need to screen this person? And sometimes I'll try to get in a colonoscopy at 80 because if it's clean, then they're good for 5 or 10 years. But obviously, that's for patients who are relatively fit and candidates again for treatment. Now, red flags for colorectal cancer, number one would be blood in the stools. Sometimes this can be bright red blood if it's in the lower GI tract on the left side. Sometimes it can present as black stools because the iron in the blood will make the bowel movements turn black. So if you see black, thick, tarry stools, that's a red flag that there's definitely bleeding going on in the GI tract, although it may not always be from cancer. So stomach ulcers would be an example of a non-cancer cause of bleeding. And this would present as iron deficiency anemia. And so when you get your lab report and you look at the hemoglobin, a normal hemoglobin is 12 to 15. There are a lot of causes of low blood counts, but if you see that you have a low blood count and there's a measure called the MCV, which tells us how big a cell is. If it's small on the small side, that could be a clue that there may be iron deficiency anemia and some sort of bleeding. Now, especially in Asians, there are some hereditary changes in the blood cells where some Asians have naturally small blood cells. So it's not a perfect test, but it's kind of an indirect clue that something could be going on. The other thing is if the stools change consistency from a normal sized thickness stool to a very pencil thin stool, that's more of like a blockage that is flattening out the stools. And especially if people develop all of a sudden or over time really loose stools all the time, that can also be a signal that there's a blockage in the GI tract because at that point, solid stool cannot easily pass through. In the same vein, severe constipation that's not relieved by stool softeners could also be a sign that there's a blockage in the colon that is just not allowing the stool to pass by. So these are things to potentially watch out for. I bring up pancreas cancer because, as we saw earlier, it's the fourth most common cause of cancer-related death expected for this year. And sadly, there is no screening test for pancreas cancer that's recommended. There are some very rare situations where we would screen it, and it would only be if we knew that a patient had a family member with a mutation that could be passed down in families, and there was a high chance that they could develop pancreas cancer. So really, unfortunately, for pancreas cancer, we're really dependent on either somebody accidentally finding a pancreas cancer because they had a scan for a different reason or certain symptoms. So, one of the most common symptoms is upper abdominal pain that often radiates to the back. It's a very specific description. The other thing is that the pancreas makes enzymes or chemicals that break down protein and fat. And so when the pancreas is replaced by cancer, it's unable to produce those enzymes. And so Protein and fat just go straight through the bowel movements, and that is why oftentimes the stools will float in the toilet rather than sinking in the water. The other interesting thing is that the pancreas helps produce insulin and regulate blood sugar. So if you have new onset diabetes, particularly in someone over the age of 50 with no family history of diabetes, that is a red flag also. If somebody all of a sudden loses their ability to control their blood sugar. This can be a tough one because diabetes itself is very, very common. And so it's not to say that if you have diabetes, you're at higher risk of pancreas cancer. That is not what I'm trying to say. It is more that if you all of a sudden develop diabetes and no one in your family, for example, has ever had diabetes, that could be a clue to your doctor that something is happening with the pancreas. The other thing is sometimes pancreas cancer can present without any pain. Unfortunately, sometimes it presents as essentially liver failure. So if it's a cancer that is close to the tunnel system that connects the liver and the pancreas, there are no nerves in that area, so people don't feel pain in a normal way. But once those tunnels get blocked, people may develop yellow skin, dark urine, gray colored stools because the pigments aren't going through. And so, if actually, regardless of being worried about pancreas cancer, if any of these things happen, then that definitely warrants a medical workup. I'd just like to talk briefly about cancer prevention, because we talked about all the ways that cancer can happen and what can we do other than screening and telling our doctor when we're worried about something that's going on. There's been a lot of research, and diet research is really hard because people never report exactly what they ate and how much they ate. And there's just so many variables involved with diet. But certainly, a broad range of fruits and vegetables, in part because the fiber will help move things through the GI tract, and obviously a lot of vitamins and minerals through the diet. Decreasing red meat and processed meat. So, processed meat has a lot of nitrates. And so, for example, for stomach cancer, that can be an increased risk factor. Obviously, we would recommend no smoking. There is concern that even with vaping and e-cigarettes, that there could be problems related to that for the lung and the inflammation caused by that. Regular physical activity has been shown to be helpful. Certainly, skin protection. We talked about the ultraviolet exposure from the sun. So, hats, sunscreen, SPF 50 would be good. Calcium and vitamin D have been shown to have some benefit. Aspirin. Aspirin in itself is not considered preventive for cancer, but in patients who have already had colon cancer, it can be secondary prevention to developing from the cancer coming back, essentially. So if you know somebody who has a history of colon cancer and has been treated for it for curative intent, aspirin should be something that they consider. And alcohol certainly is a risk factor. It's hard to say no alcohol, but certainly we would recommend in moderation, if not at all. I'd like to spend the remaining amount of time talking about cancer treatment and the complexity of decision making. Again, this is going to be very broad. I'm not going to focus on a specific cancer, but just some general principles that I like to use when meeting with patients. So I think we really have to think about what our priorities are when we treat cancer. Certainly, everybody wants to be cured of cancer, but there are some realities of such a serious disease. The primary function in my mind for treating patients is to extend their lifetime. However, while we extend the lifetime, they need to have the ability to function and enjoy the additional time that we're gaining. So, number one, extend lifetime. The second thing, obviously, we're trying to destroy and hopefully cure the cancer cells. And the third, which I think we don't talk enough about sometimes, is maintaining a patient's physical function and independence. Because if we treat a patient for cure and they end up bedbound in a nursing home for the rest of their life, sometimes we look back and say, did we really make the right decision if we took away a patient's independence? So I think it really is a balancing act. And we talk a lot about something called frailty. And it has two components. Number one, what is a patient's reserve, like physical reserve? And how much stress are we putting on them by the treatment itself? And so when we talk about patient reserve, we are looking at their medical problems. We are looking at their physical function. We are trying to assess once we do a stressor like treatment that may come with major side effects, a high or possibly low probability of cure, and potentially permanent complications. We try to make an assessment. Will this patient be able to make it through the treatment and recover on the other side? So, how do we evaluate for fitness for cancer treatment? Obviously, we're going to take a medical history. We're going to look at labs for organ function. So, if you have very low blood counts or poor liver or kidney function, that means you're going to have less reserve because our treatments are often processed through the kidney and liver and may actually decrease the function of multiple organs. A big thing we look at is actually nutrition status. And that's why I circle back to the unintentional 10-pound weight loss. Because as patients lose weight, we know that's an indirect indicator that they will have less reserve. And particularly in patients over the age of 70, we take a careful look at what is their independent functional ability. So we're interested in, is a patient active at least half the day? If we're spending more than 50% of the day in bed or in a chair, we have to ask ourselves, does it really make sense to talk about chemotherapy? Does a patient need assistance with cooking or finances? Are they able to dress and bathe independently? Or we have some patients who take a shower and then they need to take a nap because they're so tired. Interestingly, the time it takes for a person to stand from a sitting position can correlate with physical function and also the speed of walking. So the slower somebody walks at their natural speed can also be an indicator of decreased physical fitness. When we put this all into context, we have three main mechanisms of treating cancer. Number one is surgery. Number two is radiation. And number three is medications like chemotherapy. First of all, I'd like to talk about surgical decision making because when we talk about cure, for most cancers, that involves surgery. And there's really three approaches to doing an operation, and they involve increasing amounts of treatment stress. In the old days, maybe 20, 30 years ago and up to longer, surgery was always done open, which means we made the big incision across the abdomen, opened it up, and did the surgery. The bigger the incision, the bigger the stress because your body has to heal up after all of that. Probably over the past 20 years or so, more surgeries are done laparoscopic. So that's when they make the like 1 inch incisions in 3 or 4 different places. And they use sort of the cameras to do surgery with smaller incisions. And more recently, in the past 5 years, many cancer surgeries are actually being done robotically. And this has been really an amazing advancement because I have had patients even in their 80s go for surgery done in a robotic fashion, and they have been able to recover and leave the hospital within a few days. And because the incisions are smaller and the precision is there, the recovery time and some of the risks associated with open surgery have been better. Obviously, you would want to only have robotic surgery if it's what we call a high volume center. So I think it's always reasonable to ask somebody, how many cases have you done? Because obviously, if you've done more cases and have more experience, especially with the technical aspect of things, generally that is associated with better outcomes. Beyond the way the surgery is done, we also have very specific considerations about the medical fitness for surgery. The number one question we ask is, can all the cancer be removed? There are situations when a cancer is small where it's relatively straightforward. However, if a cancer has grown to the point where it's touching and attached to another organ, if a cancer has grown around a major blood vessel that cannot easily be reconstructed and could threaten an entire sort of organ system, those are situations where, as much as we want everyone to go for surgery, sometimes we have to say it is high probability we're not going to get it all out. And if we don't get it all out, we just put you through a major operation and your cancer is just going to come back in the next 6 months. And then we're in a situation where they have to recover from surgery before we could even talk about something like chemo or radiation. The second thing is, how big is the surgery? So for some pancreas cancer surgeries, parts of 4 organs come out: the pancreas, the small bowel, the liver, and the gallbladder. We think really hard before sending somebody into a pancreas surgery. However, for a straightforward colon or breast cancer surgery, I had a patient who was 92 go for colon cancer surgery that was done actually laparoscopically. So how much we're taking and how easy it is a consideration. The other thing is the anesthesia time. So for these really big operations, for esophageal cancer, pancreas cancer, it is a longer anesthesia time. And so if you have heart disease or lung disease, that could be a barrier to undergoing surgery if we don't think we can get you through the surgery and after. One of the biggest indicators of whether somebody will have a post-surgical complication is actually kidney function. So kidney function and also albumin, which is an indirect indicator of nutrition, those two things will definitely be flagged. The other thing is wound healing. So patients with diabetes, chronic steroids, any sort of blood vessel or vascular disease, people will think very carefully about surgery in those situations. I'd briefly like to talk about radiation. Radiation can be used in a variety of settings. So when we do surgery, it's usually for cure. Radiation could be used to cure cancer, usually in partnership with surgery and chemo, sometimes by itself, but it can also be used for symptom and comfort control. Some examples where we actually favor radiation over surgery could be head and neck cancer, anal rectal cancer, prostate cancer, and even early stage lung cancer. And again, sometimes the results are very good with radiation and we can preserve the function, because if a head and neck cancer patient undergoes surgery, they may be losing the ability to speak or to swallow, and those are major life-changing things. However, there are some limiting factors for radiation. So number one is the tumor size. The bigger the field is, the more radiation is given. And also, any nearby structures will be at risk. And there are certain structures that you really can't radiate, like the colon, because the bowel gets damaged so much by the radiation. And you also have to consider that there's some collateral damage to the structures around the cancer. The other thing is, in patients who are overweight, if there is a layer of fat between the skin and the organ, they have to increase the dose of radiation so that the radiation can make it through the fat and all the way to the organ itself. So there's a lot of things to consider when doing radiation. However, radiation can be a really great mechanism of pain control, especially for patients with cancer in the bones. We can use it as a targeted approach to help with comfort in addition to pain medicines. So radiation can be a really great tool. So now I'd like to talk a little bit about chemotherapy. Chemotherapy is hard and generally gets a bad reputation. And the mechanism of chemotherapy is that it disables the machinery that allows a cell to grow. And the problem with that is chemotherapy does not differentiate between a cancer cell and a normal cell. It just destroys everything. And that's why we see low blood counts, low immune system, severe nausea, vomiting, hair loss. It's because it's attacking anything that is rapidly dividing in hair, blood, the lining of our mouth and gut. Those are cells that are dividing every day. One thing I think is important to think about, especially in patients who may have a lot of medical problems or are older, is that the full dose of chemotherapy in clinical trials is generally the highest dose tolerated by humans. That's not necessarily the dose you need to have chemotherapy work. And there are some cancers where we're very aggressive and we may do three chemotherapy drugs together. Let's say you have somebody who's 30 years old, otherwise fit, and has a bad cancer. We may go really aggressive with three chemos. You can still give chemo to patients in their 80s, but we would not recommend three chemo drugs. We might do one or two at a lower dose, depending on their clinical situation. So I think it's important to hone the tool for the patient in front of you. And it doesn't have to be full dose, three drug chemo for every patient. I think we are in a different era of cancer treatment, though. We're now trying to be more personalized and really focus on the cancer cells themselves. So, probably over the past 10 to 20 years, there's been increased focus on identifying the specific changes in the circuits and the signaling to figure out, instead of just destroying the whole machinery, can we just selectively target whatever is causing the DNA or growth problem? And so now for many cancers, we do something called next generation sequencing. And what it does is it evaluates the DNA code to look for mutations or cancer variations. Now, there may be 80 to 100 code changes that we look for. Some, but not all of them, may have a non-chemo drug that's a good match for that target. Next generation sequencing is best tested on a cancer specimen. If you have a family member who's getting a biopsy, it's generally better for this testing to get it on a cancer sample from an organ, not from bone. The problem with the bone biopsy is that in order to run the test, you have to strip the calcium off of the sample. And when you strip off the calcium, you destroy the DNA, so you can't run the test. So if there is an option to do a non-bone site, that would be recommended. Sometimes there's not enough sample or bone is all you have to go for. You can draw these tests from blood, but it is limited sometimes by the quality of the sample and how much cancer DNA is floating around. But if you don't have an optimal biopsy, you could run it on a blood sample. And the reason we do this is it helps to identify targets for targeted therapy or immunotherapy. I will say that for some early stage cancers, we don't always run this because very standard treatments or surgeries may be enough to control them. So these are generally reserved for more advanced stage 3 or 4 cancers. Also, this has been approved by Medicare. So there was a time when companies were doing it for free just to show that it worked. But eventually, Medicare provided coverage for it for patients with advanced cancer where the information would be useful. So this is certainly something that should be done in patients with a new diagnosis of cancer. And here, this table is just an example for those common cancers that we talked about, what different actionable mutations and alterations we could pick up. And for many of these, there is a non-chemotherapy drug that can be used for these specific situations. Now, some of them are incredibly rare. So maybe they'll happen 1 to 2% of the time. But if you're in that 1 to 2%, that could be a life-changing situation for a really good target for your cancer. So certainly there are many options that may become available if there is a specific mutation. So targeted agents don't create the side effects we expect from chemo. We generally don't see the hair loss, severe nausea, vomiting, but the targets or the flags on the cancer cells may appear on some normal cells, and we generally know where they might appear. And so some of these drugs may cause heart failure. They may cause changes in heart rhythm. Some of them may cause electrolyte imbalances because the gatekeeping in the kidney may change. Some of these flags are found on the skin. So there's a couple of them that can cause a very severe acne-like rash. There are one or two that can actually increase your risk of skin cancer. And there are some that can also impact the lining of the eye or the way that we produce tears. And so dry eye or changes in vision are possible. And so if you're on a targeted agent, you may require some form of monitoring for these side effects or modification. The last form of treatment I'd like to talk about is immunotherapy. And this is a really big topic. As you can see, in 2018, two people, one of whom has a lab at Anderson, won the Nobel Prize for their work in immunotherapy. It has been revolutionary for lung cancer, melanoma, and kidney cancer, where we have metastatic patients who, with the right cancer characteristics, have lived for years with stage 4 lung cancer. So I have some metastatic lung cancer patients who have survived for more than 5 years. And if you go back to the times before immunotherapy, the average survival was 9 months. So this has really changed the game for some cancers. Even in rectal cancer, there was a big study reported in the New York Times where, for a very specific kind of colorectal cancer that maybe only occurs 10% of the time or less, immunotherapy basically cured patients without needing standard radiation and surgery. And so this has opened a whole new arena for cancer treatment. And interestingly, the mechanism of immunotherapy has to do with the T cells of our immune system. So, as we talked about in the beginning, part of the immune system's job is to patrol for not normal cells. What happens sometimes in figure 2 is that cancers have these purple and pink things, PD-L1 and PD-L2, that basically deactivate the T cells. So they have a connector port and it deactivates the T cell. So the T cell goes dark and cannot recognize the cancer cell. But for one of the drugs, Keytruda's pembrolizumab, what the drug does here in green is it protects the immune system cell from making that attachment so that the immune system preserves its ability to identify and help destroy cancers. So that's the general principle. And there's many different classes of these medicines, but that's an example. As far as specific testing to see if you're a candidate for a PD-L1 inhibitor, first of all, not all cancers require PD-L1 testing. So it works so well in melanoma, you don't even have to test for it. You can just use it. But certainly situations like mismatch repair deficiency, checking a PD-L1 score on a cancer sample, checking for what we call the tumor mutational burden. If it's greater than 10, that's a FDA indication for immunotherapy. So there are specific tests that we run to see if you're a candidate for immunotherapy. And in some situations, such as the PD-L1 score, depending on how high it is from 1 to 100, that can also be an indirect sign of how well it could work. As far as the side effects, immunotherapy is actually really well tolerated. The oldest person I'd given it to was 89 years old. The most common thing we see is actually low thyroid function, and we can just put you on a thyroid tablet to replace it. Maybe mild to no fatigue, maybe some dry skin. However, 5% of the time, very rarely, we can have patients experience severe life-threatening side effects where the immune system can basically turn and attack on any organ. So that can result in kidney failure, liver failure, severe shortness of breath, severe diarrhea. It is again rare, but important to talk about. The patients at highest risk of these side effects are patients who have a history of autoimmune diseases like rheumatoid arthritis, Sjogren's, juvenile diabetes, diseases that you would see a rheumatologist for, essentially. It should also be used in caution in patients with history of transplant. So we have a lot of patients now who've had kidney transplants, liver transplants. In patients with transplant, there's a 30% risk of rejection of the organ. And that is something you have to talk very seriously with somebody about because if they lose the organ, that's going to be life-threatening. In talking about all of this, I think it's important to remember that age is just a number. This picture is from the Grand Canyon. I took a walk at like 6 in the morning, and I don't think my cursor is working, but if you look at the edge of the cliff on the right, I took this picture because this couple is in their 70s, I think. And they are the ones closest to the edge, the most adventurous, most vibrant. You can tell how far away I was from them. And so I think when I meet with patients, we really have to be focused on the organ function, the functional status, and making the right adjustments for age. And so I think surgery, radiation, chemo can be on the table no matter what age you are, as long as you're physically fit for it. And I'd like to share this picture. This is one of my dear patients. I treated him for rectal cancer when he was around 88 years old, and he had chemo, surgery, radiation. And he's going to turn 100 this year. He developed prostate cancer a few years ago, and I've been treating him for prostate cancer. He developed metastatic prostate cancer during the pandemic. And so I've been treating him for the past 4 to 5 years for prostate cancer. And he will see his 100th birthday this month. And so I think he is a wonderful example of how, if we are careful and thoughtful, that we can treat patients at any age. So, just a couple things in closing. Here are just some questions you could consider asking at a visit. Obviously, what stage is my cancer? It can be a tricky question because sometimes you can only know the stage if somebody has surgery. So, if your doctor hedges and says stage 2 or 3, please, give them a little bit of latitude because they may not be able to tell you exactly. As we talked about, it's good to ask, has my cancer been tested for mutations or PD-L1 status? Basically, you're also asking them, am I a candidate for targeted therapy or immunotherapy? I think when we talk about older adults or family members, we should ask based on my health conditions and physical function, what do you think are the safest treatment options? So a doctor may tell you the national guideline. That doesn't necessarily mean that's what they think is the safest sort of option. And are there treatment modifications you can make based on my health condition and physical function? I think it's also very important to understand the risk benefit. How much additional survival time will this treatment add compared to not doing treatment or compared to doing a less aggressive form of treatment? Another one is, should I get genetic testing to see if this can be passed down in families? If you have family members who have cancer younger than age 50, or multiple cancers on the same side of the family and first degree relatives, that means grandparents, parents, aunts, and uncles all on the same side, that is worth a conversation about genetic testing. This would affect the screening for family members. And lastly, how will the treatment affect my independence and daily function? So, there have been situations where, again, we've had highly functional patients go for very aggressive surgeries and not be able to work and make it home again. And that's why I think it's very important to ask these questions because your doctor should have a good sense of how much reserve a patient has to handle the treatment we're offering. I'd also like to just briefly talk about advanced directives. When we're talking about a serious disease like cancer, it's really important to talk about advanced directives. I feel like y'all may have had a seminar about this before, but primarily, who is your medical power of attorney if you cannot make decisions for yourself? And frankly, whether or not someone has cancer, anyone over the age of 21 should have a medical power of attorney. In the state of Texas, the default would be your spouse, then it goes to your oldest child, and then down the line. Today, I met with the patient and he's married, and it became clear he wanted his youngest daughter to be the medical power of attorney because they told me his wife has cancer metastatic to the brain. And oftentimes, maybe somebody has a medical person in the family, but you have to fill out the forms and sign them. Otherwise, it'll just go down the standard law by the state of Texas. The other thing for advanced directives, what are your wishes on measures such as breathing machines and CPR? Generally, the default is that we do those aggressive measures. But particularly in the setting of a stage 4 cancer that may not be curable, I think that's an important thing to talk about with patients. We have patients who have put limits on things like this, but we still offer them chemotherapy, antibiotics, transfusion. So it's not a barrier to treatment, but it's setting a limitation on how aggressive things get. In summary, keep up with your cancer screening. Know that red flags for cancer include unintentional weight loss, changes in labs not explained by known medical problems. Maintain a healthy diet and physical activity as much as you can. In the setting of a cancer diagnosis, be open to honest conversations with your doctor about the risk versus benefit of the cancer treatment. I would highly recommend bringing a family member or close friend with you because they may hear or remember different things. And also know that there's many new treatment options that are becoming available nearly every month, and they may have less side effects and be more tailored to your cancer. So definitely worth exploring. So that's all I had, and I'll open up the floor for questions.
我们非常谢谢林医师非常精彩的演讲，你 share 他的 expertise with us。不知道各位听众有没有问题，你可以打开麦克风自己来提问。
If someone suddenly lose weight, like
Mhm.
40 pounds, gradually within 2 or 3 weeks, after colonoscopy, everything, they cannot identify the problem, then what's this possibility? Is that some cancer they unable to identify? What's your suggestion?
We get that question a fair amount. There are many causes of weight loss.
Mm-hmm.
Certainly, I would recommend checking thyroid function. Honestly, depression or even grief can manifest itself as weight loss. If there are functional issues in the movement of the GI tract, like diabetes, for example, can affect the way that the stomach releases food. So those are non-cancer causes of significant weight loss that can definitely happen. I would say if a colonoscopy was done, I would probably recommend doing a CT scan to look for any masses that might be present. The other thing might also be a rheumatology or endocrine evaluation to see if anything else might be going on.
You mentioned about the pancreas cancer, the most difficult to identify.
Yes.
What's exactly the pancreas position in our body, and are they mixed with the kidney and other part of the organ?
The pancreas is located in the upper abdomen behind the stomach and
Uh-huh.
in between the two kidneys.
Between.
And that's why, because of its location, why it manifests as upper abdominal pain radiating to the back, because it sits on top of a network of nerves, and that's why people get back pain.
Is that possible your doctor can use human being, their healthy blood to develop a strong cell, then put back to the patient's body to fighting with cancer cell?
There are two mechanisms of doing it. I did not cover that because I thought it was beyond the scope of this talk, but definitely CAR T cell and T cell therapy, they will harvest T cells and then engineer them to recognize certain cancer flags and put them back into the patient. The other way is to do transplant, for example, in leukemia and lymphoma, sort of destroying all the cancer cells and then reinfusing new immune system in. So yes, those are live in a few cancers and under study in many.
Last question. Do you recommend the Western and Chinese medicine work together to get cancer treatment?
I do actually. When we think about a lot of the original chemotherapy drugs, they are derived from plants and things found in nature. And so I think that certainly there is a harmony between the two. One thing we do look at, though, is the interactions because some of the herbal remedies may impact the liver function. And if you're on herbal medications and chemo, we really like to know because if anything happens, we're going to hold somebody's chemo. Oftentimes, we also use things like acupuncture for cancer-related symptoms and pain relief. So certainly there's a role for Eastern and Western medicine to partner together.
Thank you so much. We systematically learned the overall cancer within such short period of time.
Oh, I'm glad it was helpful. Thank you.
In the recent maybe 10, 20 years, the rate of small cell lung cancer in Oriental female has been increasing just dramatically, I should say dramatically. However, this doesn't happen in Caucasian female. Therefore, American doctor, many of them are not aware, don't have a very high awareness of this happening in Oriental population.
Mhm.
Is there any campaign to raise the awareness among the American doctors?
I think that's a really good question. And we had a very dear family friend who was in JCCAA who worked in a lab at MD Anderson that worked on the EGFR mutation for lung cancer. And it's actually not in non-small cell lung cancer.
Yes.
And it is true that EGFR mutations can happen up to 40% of the time. And the classic, even like on an exam, is that it's an Asian female who's a non-smoker.
Yes.
And this goes back to screening because even though it feels common, if you even know one person, it is not necessarily common enough to meet all the criteria of a screening test. I think in the era of AI and Google and technology, if you have a concern, going to your doctor and just flat out saying, Asian women are at high risk for EGFR mutant lung cancer, even in non-smokers. You need to do a scan because, but there has to be a reason, right? Shortness of breath, cough
Yeah.
with blood,
Mhm.
increased weight loss.
Yeah.
If you're feeling fine, it's really hard to push the issue. But I think it could
Mhm.
be that in somebody who does primary care, who has to keep up with all the new diabetes drugs, all the hypertension guidelines, monitor 50 things with every patient. they may not have the knowledge about this very specific subset of lung cancer. Certainly, I've had patients bring things to me and say, "Hey, Dr. Sada, did you know about this?" And I may learn something new. So I would say, no, I don't think there is physician education awareness campaign specifically because the target would be primary care. But I think in forums like this, understanding that this is higher risk. So certainly liver cancer, gastric cancer, non-small cell lung cancer, we see those in higher rates for Asians than we do in the general American population. So, we need to be on higher alert for things like that. That's a great question.
Dr. Sada, we have 4 questions in the chat. First one is, what are the most common myths or misinformation you have heard about regarding certain supplements can prevent cancer?
Probably the 3 things I hear about most are vitamin C, no sugar diets, ivermectin, and febendazole. I'm going to start with ivermectin and febendazole because there's a lot on the internet that suggests it's cancer treatment. Ivermectin and febendazole are so inexpensive compared to immunotherapy and targeted therapy. If there was data showing that it treated or prevented cancer, we would be handing it out like candy. And unfortunately, these drugs can be obtained over the internet, primarily from veterinary sources that are not regulated by the FDA. And I had a few patients where I've agreed to scan them while they attempted to take these medicines, and none of them have responded, and some of them have had severe side effects like diarrhea, liver dysfunction. High dose vitamin C would also be amazingly inexpensive to give, but there is not hard evidence yet to say that it is a good prevention or treatment. And I think a no sugar diet is absolutely impossible. There are natural sugars in everything we eat, if it's even fruits and vegetables. And I would caution people against taking too many supplements. First of all, it is incredibly expensive. I think that even a standard multivitamin is good. And certainly taking some herbal supplements is fine. I've had patients bring mini coolers full of supplements, and we've had to read through all of them. So I wouldn't go overboard with supplements.
The second question is, I'm a night owl. I have been wondering if staying up too late has specific link to cancer.
I'm a night owl also. I do not think there's data to support that lack of sleep will increase your risk of cancer. However, with less sleep during the day, that can definitely affect attention and alertness and feeling tired during the day, but I don't think it's associated with increased cancer risk.
The third question is the internal radiation therapy a good treatment choice for stage 2 prostate cancer?
Prostate cancer is a very complicated topic. Certainly, treatments like brachytherapy and radiation for high risk prostate cancers is certainly an option. It depends on, we classify them as mild, intermediate, or high risk, or very high risk. So, depending on the situation. But yes, brachytherapy and radiation are definitely potential treatment approaches.
The fourth one is kind of like a comment. So, in echo with what a gentleman earlier says about the lung cancer, that's not really occurs a lot in American patients. But he says that it's the same thing for the stomach cancer, which is not that common compared to Asian population. So it's not included in the normal testing.
There's no
The screening
good screening test for gastric cancer. I would say for gastric cancer, the warning signs to look out for are, again, unintentional weight loss, feeling full very quickly. So if you eat a little bit but feel like you're very full, that could be a warning sign. And also, those cancers tend to bleed. Anemia would also be a red flag. And a little bit higher up in the esophagus, if you suddenly have difficulty swallowing meat or bread, that could be a warning sign. And the other thing for Asians to be aware of is liver cancer. So in some Asian populations, hepatitis B is more prevalent. And so the risk of liver cancer is increased in that setting also.
There's another question about how do patients and healthcare providers typically balance many factors such as treatment effectiveness, quality of life, and cost when they're making the decisions?
What we talked about a lot is the science of medicine, and that I think is more the art of medicine. I think when I think in extremes, if we have a 30-year-old again who's otherwise healthy and no medical problems, we are going to recommend the most aggressive treatment. I think that sometimes when people hear cancer, they're so stressed about the diagnosis and so focused on cure. It can be hard to have a conversation about might it be better if we did less aggressive treatment that could still extend your life, but we won't cure it, and we have to live with that uncertainty. And I think it's number one, both sides being willing to be honest. And so I actually used to take a poll and I would ask every patient, do you want the straight and direct version or do you want the sugar-coated version where we don't talk about the hard things? And pretty much 99% of patients said to me, I have cancer. I'm not a doctor. I need you to tell me the truth. And what that does is it opens the door for us to talk about the hard things. And so that's at least my approach.
Is genetic testing covered by insurance? Or do you
Genetic
have to pay
testing
out?
is generally covered by insurance if you have an indication for it. So, if you have a
Okay.
strong family history of breast cancer, again, there are implications genetic testing as well. So, generally, it involves counseling because if you find out you have a genetic mutation that increases your risk of diseases, that can be very anxiety provoking for some patients. It may affect things like life insurance. It may impact decisions people make about having children. And so there's a lot that goes into genetic testing before it's even performed.
And we have one more last question. Amy, would you like to ask yourself?
Sure. This is just a follow-up
Mhm.
question was what patient just mentioned about NGS, because right now many of the samples will receive the genetic testing if, especially when there is not much option and people or the patient may seek a chance for additional cure. So based on that, we also know the tumors could be very heterogeneous, which means it comes from multiple clones.
Mhm.
So how will the NGS data help patients shape the decision in the current practice?
One of the problems is that with the NGS results, even if you have a good medicine for the target, the response may only last a few months. And so over time, the cells will develop resistance and different mechanisms of survival. And so I think it's challenging. I have a patient recently who had an unknown primary, and we had had him on a couple lines of chemo, and we found a mutation that occurs maybe 1% of the time, and we started him on a new drug. He was in liver failure like 2 weeks ago, and he is recovering and doing better since we started it. So I think we're always hoping for a miracle. And so for many of these patients, as long as they meet the minimum requirements, we'll go for it. There's some that are more clear. EGFR targeted agents have moved their way up from metastatic setting to even the postoperative setting. So I think the biggest thing, though, is cost. Many of these drugs are incredibly, incredibly expensive. Many companies have patient assistance programs that will cover the cost of many of these drugs. There can be restrictions based on whether somebody is using Medicare, but certainly the cost of the medicines is incredibly hard. I've had to call insurance companies to fight for some of these drugs because it's a hard decision. But in an age of knowing that there's a target and a meaningful drug, generally we'll try to go for it.
Thank you for answering. Yeah, I did put a example case in the chat, but I don't think you have
Oh,
to. You kind of cover most of it.
the heterogeneity is a more complex question, right? And I think the question is how aggressive is the disease that's not responding? And that's also when you get into combination therapy using chemo in addition to a targeted agent or immunotherapy. So a lot of the regimens will be chemo plus one of the agents. And so in that way, we are trying to address the fact that not every cancer cell is exactly the same. So even it's a patchwork of possibly more aggressive and less aggressive cancers all clustered together. And that's why different kinds of drugs with different mechanisms of action together are generally a more favored approach. Whereas before, we would just add more chemo. I hope that answers the question.
Sure. Yeah. Thank you, Yvonne. Yeah. We may run into each other sometime.
Okay. Yeah.
Okay, there's another new question.
Yes.
Will biopsy cause cancer?
No.
Biopsy.
No, the biopsy itself
cause
does not
cancer.
cause cancer. I will say there's maybe like a less than 1% or 1.5% risk of a biopsy sort of seeding cancer, but generally the techniques in 2025 are such that that generally does not happen. And I will say for the most part, especially with all the targets we talked about, and the fact that even among lung cancer, there's 3 or 4 different kinds of lung cancer. People will not start chemo, radiation, or do a big operation without proof of cancer. There are some specific situations, for example, kidney cancer, some forms of brain cancer, liver cancer, where for various reasons we can make the diagnosis without a biopsy, but those tend to be the exception rather than the rule.
还有任何问题吗? Is there any more questions that you would like to ask Dr. Lin? Okay, if there's no more question, we really appreciate Dr. Sada spends tonight with us and sharing your expertise with us. We really appreciate your knowledge and your talk. Thank you for sharing with us tonight.
Well, thank you so much for inviting me
Thank
today.
you. 我们下一场是要讲心脏方面的疾病，是在5月21号星期三，由 Houston 非常知名的施惠德医师为我们讲解心脏方面的疾病和治疗。欢迎大家5月21号再继续上线参加我们的医学讲座。谢谢。
Thanks.
谢谢，晚安。